quiero aprovechar la oportunidad porque nuestros profesores extranjeros ya se están retirando. Obviamente hicieron un espacio de una agenda muy, muy cargada. El doctor Klaus Monkemüller me pidió que darles un saludo. Él ya salió para el aeropuerto y esta va a ser la última presentación del doctor Ken Binmoeller, que también, terminado su plática, va por su maleta y se va para el aeropuerto. El doctor Burgos también se va en la tarde. Nuestros restos de profesores se irán un poco mañana por la mañana. Pero entonces quería aprovechar la oportunidad para agradecer a todos en especial, pero de una manera muy, muy especial, a mi gran amigo entrañable, me atrevo a decir mi hermano en la endoscopía, el doctor Ken Binmoeller, con quien tuve el privilegio de aprenderle muchas cosas de nuestra estancia en Hamburgo, desde luego con el maestro Nipso Gendra. Ken, muchas gracias por venir, que tengas un excelente viaje de regreso a casa, te deseamos la mayor de las bendiciones, mucha salud, muchos éxitos y estamos en contacto.
Angel, Mr. President, thank you for those very touching words, and I want to also express my reciprocal gratitude to you for inviting me and for the opportunity to be part of your outstanding meeting this year. So my last talk will be on EUS in the 20s. Whenever I'm asked to talk about the future, I get a little nervous because, as the famous baseball player Yogi Berra said, the future ain't what it used to be. But it is remarkable how rapidly EUS has evolved within the span of just 3 decades. It started as a purely imaging procedure with the radial scanning echo endoscope. That's when Angel and I first met in Hamburg, and all we had was a radial scanning instrument. There was no interventional EUS. But then it rapidly evolved in the 90s to interventional with FNA, which is still diagnostic, but the real excitement is therapy, our ability to use the echo endoscope as an imaging tool to guide endoscopic therapy. EUS-guided FNA is truly the birth of notes because the endoscopist now has access to structures outside of the GI tract, neighboring organs, lymph nodes, and periintestinal masses, and fluid collections. We can substitute the A for an I for inject, and we can inject a variety of solutions. It can be a steroid solution and we can perform a nerve block. It can be a sclerosant for neurolysis, for celiac neurolysis, for example, or it could be tumor ablation. We can inject cyanoacrylate glue, as you heard yesterday, for hemostasis, and it can be a chemotherapeutic drug, and that, I think, is an area we're going to hear much more about in the 20s. Yesterday, I touched on a procedure called EPIC, EUS-guided portal injection chemotherapy. We have very unique access to the portal vein, which the interventional radiologist does not. And so it lends the possibility that we can selectively concentrate the chemotherapy into our targeted organ and minimize the systemic toxicity of the chemotherapy. That I can also stand for implant. So that implant could be a fiducial, and that can be used to guide oncologic radiotherapy. Or it can be a radiation seed that will enable tumor ablation. It can be a thermal device. It could be both hot or cold, and that can enable tumor ablation. And it can be a coil, as you also heard yesterday, and we can use that for hemostasis. So in the picture shown below, we can see fiducials that can be loaded into our FNA needle, and you can see the radiation seeds that we can implant under ultrasound visualization, And this would be a prototype of an RFA device, a radiofrequency ablation device. There are others now in development. And this is a coil being deployed from the FNA needle. Yesterday you heard about the combination of coil and glue. So we're combining a device, an implant, and we're using a solution, the cyanoacrylate glue, to treat gastric varices. And that implant could be a Guidewire. Now that seems very intuitive, but in fact, that is how we started doing Rendezvous ERCP. The indication would be for failed cannulation of the bile or the pancreatic duct. So in the images here, you can see how going transhepatic, transgastric, transhepatic, we can access the left hepatic duct and we can feed our Guidewire across the stenosis or the blockage into the duodenum. Then we switch out for a duodenoscope to complete the ERCP. We call that Rendezvous ERCP, or the pancreatic duct. Access transgastric and advance it into the duodenum. So these over-the-wire interventions, which radiologists have been using for decades now, we call that the Sodinger technique. And we have adapted that, and that has enabled us to perform drainage of fluid collections outside the gastrointestinal tract. For example, pseudocysts. So the first step is to access the cyst with an FNA needle. Then we insert the Guidewire into the cyst. The third step is to dilate the tract. We can use a balloon as shown here, typically a 4 or 6 millimeter. This is merely to prime the tract so that we can subsequently perform stent drainage. And we may place one or multiple stents. The Sodinger technique, adapted from our radiologists. But when we use the Sodinger technique, we must bear in mind that with each of these steps, we take some risk. So we start with the needle puncture, the wire goes through the needle, but when we remove that needle, there is a step off between the wire and the tract that we've created. There can be leakage. We need to insert a dilator over the wire to dilate the tract. This can displace the lesion. Dilation over the wire can result in perforation. Removing the dilator can result in leak. And when we insert our device, a stent, over the wire, this can result in displacement. Low battery. Plug it in, please. So what is different when we use the Sodinger technique compared to the radiologist coming from the outside is that we are essentially creating an intentional perforation. So avoiding leakage is the challenge that we face. Of course, when we're dealing with a pseudocyst that's adherent to the GI tract, that's not an issue, but it is an issue when you have the gallbladder shown here. There is a space interposed that's echogenic, that's fat tissue. This is not adherent to the GI tract. And therefore, if you look surgically after placement of your stent, you'll see that the stent is in the free space between your target organ and the GI tract. So what we have lacked are tools dedicated for transluminal therapy. Can you please go back one? In this cartoon, the boy is asking, "Where are your tools?" And the plumber, that's us, is saying, "Huh?" Because that's really where we were before. So that inspired me to think outside the box about tools that can be developed for dedicated transluminal therapy to prevent leak and perforation. And there were two tools that I felt we needed. Firstly, we needed a transluminal stent, and we needed a transluminal stent delivery system. And that stent should be covered and self-expanding to seal off the tract, should be lumen-apposing, and it should provide a port for transluminal intervention. In other words, we can pass our endoscope through that as a port to the extraintestinal space. And our transluminal stent delivery system should eliminate all over the wire exchange. It should be non-Sodinger, and it should allow us to access the target lumen with the stent-loaded catheter. And these are drawings from the patents that I filed back in 2005 when I started thinking about these concepts. We call this today a lumen-apposing metal stent. It's a transluminal drainage stent, or even an anastomotic stent that holds 2 lumens in apposition. It has a functional equivalent to surgical anastomosis. It seals and it tamponods, so if there are any bleeding vessels, they are tamponaded by the expanding stent, and it provides this port for transluminal endoscopy. The Axial Slams, which you see shown here, has 4 key features. It's made of a self-expanding alloy mesh, nitinol. It has anchoring double-walled flanges. That construction is very critical for its lumen apposition and strong pull-out forces that resist pull-out. The short saddle of only 1 centimeter, and it is fully covered with silicone. I like names. I was trying to come up with a name that captures the spirit, the essence of the device. And this name Axios is an abbreviation of Axial Ostomy. This is how we work. We work coaxially. It's an axial instrument, and we are creating an anastomosis, an ostomy. So that becomes Axios. And how befitting, because Axios is also the name of the Greek river god. So it is enabling flow from our extraintestinal space to the intraintestinal space. The transluminal delivery system should be 1 step, 1 device, exchange-free. This is what is unique about endoscopic intervention, that our tools are so remarkably clever, and they allow us to do procedures in such short periods of time because they are designed for simplicity. Just think about the snare. Our most remarkable instruments are our simplest instruments. We can access the target lumen with a device-loaded catheter and then immediately deploy our device without any over-the-guidewire exchange. Developing an exchange-free delivery system is no easy task, though. There are many technical challenges. If we use a bougie, there is difficulty with wall penetration. It often buckles as we're trying to push the bougie through the wall. And we may displace our target away from the GI wall. If we use a balloon, again, we have the problem of difficult wall penetration. We can perforate and we can have bleeding when we dilate our balloon. We can use an incisional instrument, but this may result in bleeding. So if we just use cutting, that has risks. And if we use electrocautery, for example, with the needle knives, this may result in thermal injury and it may burn a hole in the wall, a needle knife or a cystotome. So that inspired me to think about a different kind of platform that would minimize the coagulation effect and maximize or optimize the cutting effect. And that led to the development of the hot Axios. You can see these are micro wires that run along the sides in a radial fashion of a bougie-shaped ceramic tip. It's very hard and firm, and these wires then converge at the very tip like this in a circular fashion, so that we concentrate the electrosurgical current along a very small surface area. It's only 3% of the surface area of this tip here. So we puncture, we deploy our distal flange, and then immediately our proximal flange. And the distance here is only 1 centimeter. And for that reason, there is no room for error. The delivery must be very precise and 100% accurate, and therefore it should be endoscopist controlled. So this lure locks, just like an FNA needle, to the port, biopsy port of the echo endoscope, And there is a two-stage release as a safety factor. You release the distal flange completely independent of the proximal flange. And there's a full stop in between the deployment of the distal flange and the proximal flange with a click in between. So it guarantees that you don't accidentally deploy the entire stent. So the LAM serves as a port for endotherapy, and that is the window that we have needed, the platform that we have needed to extend the reach of the endoscope into the extraintestinal space. So our first and obvious applications were for nekrossectomy. So you can see how through the Axial stent, we can deploy the tools that we otherwise use for other indications in the GI tract to, for example, remove necroses using this net basket. So we can pull these right through the lumen, and we can re-enter as many times as you like with much greater ease, and we can even place a cap over the tip of the endoscope. As you can see here, this is something I like to do, and apply suction because I like to preferentially remove the loose necroses, and I leave the adherent necroses to debride or auto-debride with your own stomach acid, which is why I take patients always off of their PPIs after doing cyst drainage. This can be a port for endotherapy in the gallbladder, and Anthony Teo in Hong Kong very nicely described a long list of applications in the gallbladder. Because he's able to pass the endoscope into the gallbladder, not only can he capture stones and remove them with baskets, for example, he can also perform lithotripsy. You can see that down here. Here you can see a stone captured with a basket. He even performed EUS with a mini probe, confocal, microscopy, endocytoscopy. So it extends not just the therapeutic reach, but also the diagnostic reach of the endoscopist. So the LAM's applications can be divided into three categories: pancreaticobiliary, where we can drain pancreatic fluid collections, the gallbladder, the bile duct. Then the second category is enteric. We can create a small bowel anastomosis, a gastrojejunostomy, and in patients with a bypass stomach, we can create a gastrogastrostomy. And now emerging are the, quote, off-label uses for luminal applications. We can treat pyloric stenoses and short strictures. So where are we today, and where might we be in the future, in the 20s, for example? So for EUS-guided gallbladder drainage for gallstone cholecystitis, here are our current applications. These are poor candidates for external drainage. They are non-surgical candidates who require long-term drainage, or it might be a patient with an external drain in place who needs internalization. But to be answered before we can extend these applications to perhaps patients with gallstones in general, we need to determine the cure and durability of endoscopic treatment, the long-term adverse effects, and the impact on a future cholecystectomy. For the bile duct, current application would be only for patients with failed ERCP and a non-surgical candidate. To be answered, again, what is the cure and durability of this treatment? What are the long-term adverse effects? And what is the impact on future surgery, such as a Whipple operation, if that were to be done in the future? For a gastroenterostomy, the current application would only be for failed duodenal stenting in a non-surgical candidate, or in a patient who already has ingrowth into their duodenal stent, so we need to find an alternative solution. Again, the same questions need to be answered about durability and adverse events and the impact on future surgery. And then what we're seeing, regrettably, so much of in the United States at least, We have patients who have had gastric bypasses where we have great difficulty reaching the ampulla for ERCP, but also remember that the remnant stomach is excluded, and we may want to exclude an ulcer, for example, or cancer in the stomach. Currently, just for failed deep enteroscopy, which is where we cannot reach the stomach or the duodenum or ampulla, or when we fail ERCP, which of course becomes much more challenging through a enteroscope. To be answered, the timing of the intervention, when do we perform that ERCP, same session or separate session? What about the weight gain after gastroenterostomy, and what about long-term adverse effects? The future looks very bright for EUS because if we can expand or extend the reach of the endoscope to structures outside the GI tract, then really only the imagination is the limit. These are all the organs that surround the GI tract. The GI tract is literally our inside window to all of these vital organs, starting up at the thyroid all the way down to the prostate. So all of these could be fair game for extending our reach. Thank you very much.